So we welcome you all for the today's panel discussion, Bridging the Gap Between Oncology and Fertility team. So we have with us the most eminent panelists from both the field, oncology and fertility. And we thank all the panelists for joining our workshop. So the panelists are, we have with us Dr. Bahusaheb Bagal, a professor and consultant medical oncologist, Tata Memorial Centre, Mumbai. Dr. Amit Joshi, consultant medical oncologist, Tata Memorial Hospital, Mumbai. Dr. Sampata Desai, consultant surgical oncology, Sir H.N. Reliance Foundation Hospital and Research Centre, Mumbai. Dr. Satish Tibrewala, medical director, Fertility Care India Private Limited, Mumbai. Dr. Chaitra Nayak, senior fertility consultant, Cloud9 Hospital, Bangalore. Dr. Anjali Sharma, Senior Fertility Consultant, Indira IVF Center, Allahabad. Dr. Swarna Rathod, Reproductive Medicine Consultant, Baby Sure Fertility Center, Pune. We welcome you all. So I think we shall start off with the panel discussion. So Dr. Snehal and myself, we will be moderating the session.
Yeah, so we will have the basically can we just next slide please. So yeah, meanwhile we get a next slide. So this will go by this route. So the case scenario, because primary care physician are oncologists, so we will see their review, what exactly is happening at their end, what initial primary discussion. Then when the patient comes to us at that level, what we are giving the counseling and the option. Again, the patient is going back to the oncologist, and then again after the follow-up, after the completion of the treatment, after their follow-up, with their consent, when they come to us for the pregnancy. So we will complete all this circle. So we'll go on to the next first case. Yeah.
So I think so. This is I have changed. So the first clinical scenario is a 23-year-old man who is diagnosed with acute myeloid leukemia, where it's confirmed with the flow cytometry showing immunophenotype consistent with acute myeloid leukemia.
Okay, so I request Dr. Bagal to comment on this. This is the case of the hematological malignancy, 23-year-old man. So first, when it comes to you, can you put your reviews on that?
Yeah. So thank you for this opportunity to participate in this discussion. I think really interesting and need of time to discuss these niche areas even in oncology community. I deal with hematological malignancy. So a 23-year male who is post-pubertal and has a diagnosis of acute myeloid leukemia. So first of all, one point I'd like to put forth is not all hematological malignancies are the same. Or for that example, not all acute myeloid leukemias would be same. And the disease course may vary from patient to patient. So whenever we are faced with such situation, we try and dissect out what are the patient who have emergency and they need immediate treatment. So this patient typically would be patient with hyperleukocytosis, patient with coagulopathies, patient with severe cytopenias, or someone having a mediastinal mass with impending respiratory or cardiovascular compromise. In such cases, their treatment needs to be started, and unfortunately, in certain situations, we may not have time for discussing or trying fertility preservation in such patient.
Yes.
But in most of the patient, we will have time, and we will also have a window of opportunity to deal in such situation. So definitely in other patients, we discuss fertility impact of this thing.
Yes. Yeah. Sorry. You were saying something.
No, I think I
Yeah.
can take
Okay. Yeah. Thank you for your insight. So, suppose we assume that we have little bit time, and he is now 23 years. So, I request Dr. Tibrewala sir to comment on that, like how we go about for the fertility preservation in this particularly young man who has got this hematological malignancy. I think The volume is not clear, sir. Sir, volume is not clear. Your voice.
Sir is on mute, I think.
Mute. Yeah.
Yeah. Okay. Now
Yes,
can you
yes,
hear
sir.
me?
Now audible. Yes, sir.
Because I was muted, so
Yeah,
that
okay,
was
okay.
the.
Yeah, yeah. Now it's clear. Yeah.
Yeah, good. So I need to know whether this man is married or not.
So this man is married. Yes.
Yeah. So he is sexually active.
Yes.
He is a sexually active married man. Does he have any children
No,
at
no,
present?
no.
No. Okay. So this is an active man, married, but he has no children. So he is having semen for sure. And talking to him about producing semen sample is not going to be an embarrassing situation.
Yes.
We have to explain to him, and as doctor has mentioned, that we have time, some time, although there is an urgent need to start, but we have enough time to ask the young man to give us enough samples over a period of 10 to 12 days so that they can be frozen. And with the newer techniques of cryopreservation by vitrification, we are able to have a very, very good post-thaw sperm count and motility. That is one thing. So that kind of counseling has to be done. Secondly, we have to not just presume that the wife is okay, we have to make sure that the wife is also evaluated before we advise the man to undergo any kind of therapy for cryopreservation. And like in any other infertility patient, the general examination, systemic examination, and history taking is very important. So we cannot just take it for granted that there will be nothing in the history that will need attention and that nothing will be there in the clinical evaluation that will need attention. So all that has to be done, and then he is advised to give a semen sample. If the native sample is found to be good, very highly motile sperms, good concentration, then it can be frozen as it is. But if it is found to be a little subnormal, then maybe it can be processed and concentrated and then stored to be used later. Now, if his therapy is started, should I go on with that, or then we can say
So
that
we can, sir, we can discuss about the options basically.
Yeah. So the first option is semen cryopreservation by vitrification. Second is, in case he has difficulty in collecting a sample because now he's been diagnosed with cancer, although he may otherwise have been able to give a sample, then he may need a little help from the center by providing a vibrator or some kind of TV and some movies to be shown, which will help him to get a good erection and ejaculation. If we find that his semen is azoospermic, if he is an azoospermic man because he has not proven his fertility yet, then we have to go for other alternatives, and that I can talk now, or you want to bring that up later?
Yes, sir. We will take the next case for the surgical
Okay,
extraction.
Okay, so I won't talk on that. So
Yes.
that is one thing. Now, secondly, we have to tell him that even after everything is done, the pregnancy rate is around 20 to 30% with frozen sperm, which are where the native sample is good. And if at all the native sample is not very good but subnormal, even then he can go for IVF ET at a later stage where the success rate can be as high as 50% per cycle with the frozen sperms. So that is one thing. And I suppose you have to talk about the method which is going to be undertaken. If it's just cryopreservation and thawing and insemination at a later stage, then the cost is going to be very, very low. But if it is going to be IVF ET, then that has to be discussed at an earlier stage before going any further. If he turns out to be azoospermic, and later on you're going to talk about sperm extraction, microdissection, and extraction. But at this stage itself, if we find that he is azoospermic, or if he is severely oligospermic, I would subject him to microdeletion studies. Because if my Y microdeletion study confirms that he has a particular kind of deletion, then even if he is subjected later on to sperm extraction, then the chances of finding sperms are very minimal or nil in certain cases of Y deletion. So that study should be done before he is advised to go for deletions, extractions, sperm extractions. I'll leave that to you to bring it up at whenever you think it's convenient, relevant.
Yes, sir. Yes, sir. That is absolutely true. That this was very important point that we need to go for the Y microdeletion studies if initially before going for the invasive options. So definitely the first preference would be the sperm cryopreservation. If not, then we can go for the surgical options that we will discuss in detail in the next case. But yes, this is one important point as Dr. Bagal also rightly said. We need to each case is different, so we need to assess the time. That definitely important coordination with the oncologist. But this is very important that even though there is a significant emotional stress and difficulty, it is very important to discuss this at the point of the diagnosis. And as sir also rightly said, that we need to discuss all the factors, what will be the costs involved, what are the further things, even the counseling of the spouse, wife, as well as the families, and then later on what options do we have, and we need to discuss in all these aspects. Thank
Can
you,
I
sir.
interrupt you just
Yes,
a
sir.
second?
Yes, sir. Yes, sir.
Yeah, discussion with the family. Before entering into discussion with the family, the couple has to be taken into confidence whether they
Yes.
want to disclose this to the family or not.
Yes, yes.
There are pros and cons of it.
Yes.
Because they may be wanting and the family may oppose. But the pro is that if they need any financial support and the family knows, the family may pitch in for that. So,
Correct.
the couple has to decide whether the family should be informed about this.
Yes, sir. Yes, sir. Because it's individual right, definitely, sir. So
Correct.
we will move on to the next case.
This is regarding a 12-year-old boy who had relapsed acute lymphoblastic leukemia 4 years after the completion of standard risk leukemia treatment. Diagnostic and staging assessment confirmed that he had a combined bone marrow, CNS, and left-sided testicular relapse. He did not have fertility preservation at the commencement of his initial diagnosis. He has a sparse, faintly pigmented pubic hair and the testicular volume of 8 ml. He has erection and wet dreams but had not masturbated before. He became very embarrassed having this conversation with his parents, felt that it was not relevant. The parents also felt that it was not relevant to ask their son about these questions.
Yes. So this is the challenging case of the almost a boy just at the level of the puberty. So first, I would like to ask Dr. Joshi about it, like from the oncologist perspective. How can you provide insight on this case?
I think Dr. Bhausa will be a better person because I deal with the solid tumors. So I think
Okay, sir. Okay.
But whatever I can, if there is a CNS involvement, the prognosis is not going to be very great. That I can say. I think about
Okay.
further take.
Yeah, sure, sir. So I think coming back to assessment of individual patient, so we have to determine the prognosis, the required treatment, the chances of infertility with that treatment, and this case actually highlights that. So depending upon the treatment modality, which are going to use chemotherapy, stem cell transplant, radiation involving brain as well as testes, we have to factor into the person's chance of infertility. So for this person, he is going to require a salvage chemotherapy, and that would be followed by a transplant, which will also require probably total body irradiation. So his chances of infertility are very high unless and until we offer him the preservation. And I think is pivotal, and if it is easily feasible, and looking at his parameters like his counts, his performance status, hopefully we would have some time to preserve the sperms.
Okay, sir. Thank you, sir. So I would again.
The most important thing in taking these sorts of decision is the prognosis. So the most
Yes.
difficult question as an oncologist, what we feel about whenever we discuss the fertility issue at a basic, the question is that how the patient is going to do in long term.
Yes.
So at that point of time, discussing fertility issue in a case where we know that the prognosis is not going to be very, very great, it's very difficult to make a balance
Yes.
between the decision of a continuing chemotherapy or planning some very intense chemotherapy, and in the background then we have to discuss about the fertility also. So that becomes a very, very challenging job as an oncologist. For other cases where prognosis is good, we push them from our side to get all these things. But in a disease where prognosis is not going to be very
Yes,
great.
sir, I agree with you, sir. Prognosis needs to be, and then only the need of fertility
Yes.
preservation can be discussed. So this is a 12-year-old boy, and he has a pretty long progression-free interval, almost 6 years. And looking at means childhood ALL salvage rate, he still should have a cure rate which should exceed 40-50%. So I still would want, if possible, preservation of sperm, sir.
Yes, sir. Yes, sir. Because this is really challenging with respect to the prognosis and how we deal with this. Because it is, as it is very distressing situation. Cancer diagnosis itself is a lot of stress, and at that point of time, discussing fertility, that might give a false sense sometimes to the parents that yes, I mean it is a very good prognosis. That also shouldn't happen. So this is very challenging in that part. So definitely, I would like to ask Dr. Tibrewala sir about the further options, like in such a situations, how to deal with that, and of course we can discuss in this the surgical extraction options.
As Sangeeta had mentioned, that the category gonadotoxic categories can be four, no risk, low risk, intermediate risk, and high risk. No risk is 0, low risk is 0 to 20%, 20 to 80% is intermediate risk, and over 80% is high risk. Now, I think that this child of 12-year-old boy would probably fall into the high risk group. If he falls into the intermediate or the high risk group, he is the person who definitely needs counseling on preservation. We need to take the help of a counselor who is a pediatric counselor, not a counselor who deals with adults, because the counseling will have to be done at a different level, a different age level. So a pediatric counselor would be ideal to help in that case. Now, parents have to be taken into consideration here, because this boy is too young to take decisions on his own, and his parents feel that his son should not be asked these questions. So the parents will also need some counseling to make them realize that this is the quality of life that is going to be affected when the child grows up. Of course, he's at a high risk. What his survival rates are, that will also have to be discussed, right? So that is one thing. So now in this case, there's no question of getting any semen, because he's only 12, and although he's saying he's having wet dreams, which I doubt at 12 years of age, but anyway, the chances of getting sperms from a semen sample, even if he is convinced to produce a sample, will be very low. So you can try percutaneous sperm aspiration from the epididymis if the epididymis looks a little distended, which is a very simple procedure rather than doing a microtessay and extracting the tissue. And then that tissue, of course, if we find that there are no sperms at all anywhere, then that tissue has to be used for freezing. And testicular tissue freezing is done at many centers, even in India. So that is not a problem, and it can be used. But in this case, if no sperms are there at all, then what we are looking at is in vitro maturation of sperms at a later stage, when the technique does develop, because you may get spermatogonia at particular, in certain of the tubules, and the spermatogonia, the sperm, these are known as the premature sperm cells, the spermatogonia at the basal level, and they can be used, and techniques can develop to mature these spermatogonia into sperms when it's available and it can be used. But at this stage, I doubt we will find sperms in the testes, even with even with microtessay. But that is an option to be kept in mind. And of course, more important is the freezing of the testicular tissue for use at a later stage.
I think some problem with the voice.
This child is also looks like he is, with sparse, faintly pigmented pubic hair. He is not yet a tanner staging. So if he had not had this cancer problem, we might have stimulated him with some kind of hormones. But because of his cancer, we cannot have that much time on hand. So whatever the best that can be done is testicular tissue freezing for use at a later stage. Thank you.
Okay, sir. Yeah, thank you so much, sir. Yeah.
Hello?
Hello. Yeah.
Yeah.
So
Yes, sir.
what are the charges for this? How when we have to counsel the patient, the testicular freezing, how is there any like a yearly charges like a sperm preservation? So
Yes.
if you can brief it, that will be helpful.
I would like to ask Snehal if they are
Yes, sir.
doing testicular tissue freezing. Are you?
So basically now testicular freezing, it is like it is still a experimental technique. So we need a institutional review board for that. We have that all the facilities. Still, we are not currently doing it because accordingly it has to be we need to take a review from the ethical board, and then definitely, but we can very well do. So costing, as sir was asking, so it depends upon the TISA costing and or the micro TISA. So generally TISA costings would go for up to 40,000 procedure costs, and the micro TISA would be around 80,000 at our settings, and then the freezing costs are there. So for the 1 year, generally it is the 10,000 for a yearly freezing, and we need to renew every year. Maybe now that is also one point we have to discuss, that we have put it about the costings and all, because still these kind of things, it is not involved in any insurances. Even the trusts which are there for the cancer treatments, they are not giving the funds for the fertility preservation. They are giving the funds for the treatments. Of course, the insurance policies, they are covering the complications like iatrogenic complications of the cancer treatment. But of course, yes, that infertility is also one of the iatrogenic complications which has to be covered. It is still not covered, so it's a big debate. So we need to make arrangements, then only it will be feasible and more accessible to the people. So of course we have all the facilities, but still we are having these challenges. So to take forward these kind of cases.
No, I want to ask you one thing.
Yes,
that in
sir.
India, you said that testicular tissue freezing is not allowed, or it's
No,
allowed?
it is allowed. It is allowed. It is experimental technique, so that it is allowed with the institutional review board committee. When you have, so it has to be with that committee, get approval, and accordingly we can go ahead with the cases.
So ICMR has no guidelines on this?
No, ICMR yet has no guidelines on this.
Okay.
Yeah.
Do you know any center in India that is doing in vitro maturation of spermatogonial cells?
No, not in India. There are centers well developed in the US, UK, and of course Canada, because there is a lot of work going on there. They have the Oncofertility consortiums and all, but not here yet. Yes.
Okay.
So basically, still there is a lot of raw area in this field.
Yeah, I don't think you'll get any sperms out of the testicular tissue that you extract.
Yeah.
That is my, that's my take on this. At 12 years of age, chances are very, very minimal.
Yes.
And already you're saying that he has only sparse hair, pubic hair, so he's probably not
Yes,
even
in
had
this case,
proper
definitely.
maturity, So that's one thing. Now this is showing the testicular sperm extraction. I think Sangeeta is in a better situation to answer this technique,
Yeah.
or you maybe.
Yeah. So testicular tissue. Yeah.
So this testicular tissue cryopreservation, where usually here in TISA, where we get the biopsied sample, we tease them, and here along with the culture media which had sperm, even we freeze the testicular tissue also, because later, in case if we want to, if we have utilized one vial, and if we later want to see whether we can tease those tissues also to get the sperm and reuse it. So we usually freeze it as two. One as the sperm suspension with the culture media, and one as a testicular tissue. But these are in patients where we find sperm. But if we do not find any sperm, it's no point in freezing the testicular tissue. So here, when the testicular biopsy is done, we get a very small piece of tissue, where all the tissue pieces are teased, minced. We take it and store it in the cryo vial, and as I said, it's in two ways. One is a sperm cell suspension, another as a testicular tissue for later use in case if we have to extract or tease them, so that unnecessary repeat of another teaser we can avoid them. And we store them, we subject them with a cryoprotecting solution, and we don't vitrify, we use a rapid freezing technique. And these samples later can be used for either stem cell transplantation, tissue grafting, or tissue culture, which is not, we are not practicing it yet. These are still an experimental procedure.
Yeah, I'd like to add something here, that you know, when they do microscopic evaluation after making a cut, they are able to identify certain areas which look, where the seminiferous tubules look more full, you know.
Yes.
And these are the tubules which can be extracted, cut and removed, so that you can look for sperms in that, rather than going blindly and making multiple punch biopsies and, you know, then looking for sperms in all the biopsies. So
Yes.
microcopy has some advantage over the others, but there are some people who believe that instead of just making one incision, small incision, and trying to look for the sperms in that, from the tissue from that incision, when I spoke to some doctors who had come from USA, they said that we completely by you know, they open up the testes into two halves, like what it looks like in this diagram over here.
Yes.
And then they open it up into two halves, and then they look under the microscope to look at the tubules which look more distended. The tubules which look more distended are the ones where you are more likely to find the sperms. So then they say then we take those tubules and cut it, because the embryologist, Sangeeta will probably agree with this, the embryologist goes mad looking for sperms if you give them lots and lots of tissues to look for. And if the chances of finding sperm in that particular sample is very low. You know, it takes 6 to 8 hours to look for sperms in some of the samples, tissue samples. So if you can directly look under the microscope and decide which area to cut and extract, it may be better. I'm sure Sangeeta would be happier with that.
Yes. Yeah. Yes, sir. Thank you so much, sir. So, sir, I would like to, because,
Can I ask
yes, sir.
one question?
Yes, sir.
Suppose like in a testicular cancer patient, the archidectomy is done at a different, initially the sperm analysis was tried and it was found that it was not, it was agiospermic. Can this be technique and the patient underwent archidectomy? Can the tissue can be transferred to other place to get it, or it should be done at this micro test to be done at the same place, or it can be transferred to the other place for 2 hours, 3 hours, and then the rest will be done at that place?
Yes. So basically,
I
sir,
think, you know, that if a patient has got testicular cancer, then this is not a testis from which you want to get sperms out, even if the whole testis has been removed and kept aside. What do you say, Snehal?
yes, sir. Actually, if it's a testicular cancer, it is not ideally from the deceased testes. But if in case the orchidectomy has been done and the other testes, if suppose it is normal morphologically, maybe yes, we can go ahead and have the tissue preservation. And as sir was asking, like it can be, see, ideally it should be at the same center. And I think for the transport, I would like Sangeeta to add some insights for the transport of the tissue. You think how many hours? Like
It should be almost.
Louder, please.
Yeah, sorry. Hello.
Yeah.
Sorry, usually we do not transport the tissues, and even if we want to, it should be like it is pre-warmed, and the transport should have the warming facilities to transport to the another center, and the other center should also have the ability to freeze that. So the freezing techniques, everything should be followed under aseptic precautions.
Yeah. So ideally, we would like to do it at the same setting. That's why, sir, ideally it should be a institutional where we have the fertility unit in the multi-speciality hospital. Basically, that is very important. And then the oncology unit at the same building or whatever, same hospital where we have the same facilities. And immediately we can, take forward these kind of, especially ovarian tissue and testicular tissue cryopreservation. That's why we need a multidisciplinary team. So it has to be there at one setting ideally.
I'd like to ask one question to our oncologists present here today. What are the chances of the other contralateral testes developing cancer at a later stage if it is left?
Yeah, sir. So by the definition or by the whatever the data we have, it's around 1 to 2% patient may have chances of developing the condition. It's not very high. If we are giving chemotherapy, suppose for this one testis which has affected, even with the chemotherapy, though there is a theoretically a blood testis barrier, but we have seen that the some amount of chemotherapy may pass through this barrier and will kill the tumor cell there also. So patients who have received chemotherapy have undergone architectomy of one side, the other testis getting testicular cancer in due course of time is around 1%. So mostly it's not that. Those patients who have not undergone chemotherapy still incidence maybe is little bit more, but after chemotherapy it's around 1 to 2%.
So we can actually get tissue out of the contralateral testes and look for sperms and store them if they are there, right? Or
Yes.
before starting chemotherapy.
Yes, ideally, yeah.
Anyone from Tata want to answer that?
Yeah, so I agree with Dr. Amit, the chance is really low to have it, but for certain, I mean, it will vary from disease to disease. For example, testicular lymphoma, the chance of contralateral testicular involvement is very high, and in that case, you will require a prophylactic radiation to be given. So that's for sure. Infertility for that test is also. So in other tumors might be low, but certain diseases, for example, this kid had a testicular relapse of acute lymphoblastic lymphoma. So situation here is going to be more complicated, and is contralateral testis will not be available for that. Sir.
Yes, sure. Yeah. Yes, sir. So, actually, Dr. Tibirwala sir had to log out early. So, I would like to ask sir if any insights on final comments on the strategies on the male preservation, because after this we'll be starting the cases of the female cancers. So, with these two, yes, sir.
Yeah. So case 3 you're not taking up, right?
Yes, sir. Yeah, sir.
Okay, fine. I'll keep that paper aside.
Yeah.
Okay, now I have made some notes over here. I have spoken to some fertility specialists, Dr. Sonia Malik, who is from Delhi, who's doing a lot of work in Delhi, very well-known gynecologist. So I spoke to her and she says I get around 3 to 5 cases for fertility preservation in the male and per month. So that comes to about how much? 14, 15, 20 maybe cases in a year.
Yeah.
And she says they are only doing cryopreservation of sperm, and they are looking into cryopreservation of testicular tissue. They do freeze some of the tissue so that if IVF is required later on, they can look for sperms in the frozen tissue also. Okay, in case that this microtase is being done. But if enough sperms are found from a sperm sample, then they freeze enough samples so that it can be used at a later stage. And she said that it's very, very important that this is a message from her to our group today that is meeting, that we should have some kind of a guideline and that we should have dedicated centers, oncofertility centers in India, because otherwise what is happening, every fertility center starts thinking of preserving, tissues for later use, then they will not get enough information and they will not get enough samples and tissues. So it's better to have dedicated centers which will be doing oncofertility work, and every hospital that is doing treatment for cancer should be made mandatory to have fertility counseling at that hospital. Whether they have a center or not, they should at least have a fertility counseling. She said that at the center, which is this hospital in Delhi, where it has been made mandatory, the Max Center, right, in Delhi, they have made it mandatory for every cancer patient to go for fertility counseling, whether they go for preservation or not, but some kind of counseling they have to undergo before they go for the therapy. That is one message. Second message I have from Dr. Rishikesh Pai from Bombay, who said that, we just like we were discussing that why don't we have guidelines in India, just like they have guidelines abroad in USA and Canada and Europe. So we need to approach ICMR to formulate some guidelines for the Indian population, and that can be made available to all the centers which are treating cancer patients, so that they can know what guidelines are available, what guidelines are there for them to decide which patients have to be referred. Actually, counseling should be done for every patient, but then the counselor and the doctor can decide whether this patient should be referred to a center or not, but guidelines should come from ICMR.
Yes.
Another thing they said is that, when we are preserving the tissues, whether it is, sperms or whether we are preserving embryos, we are finding that 80% of the patients never come back, for use of the frozen samples, whether it's embryo or whether it is sperm. And they are saying a lot of it is because many of them conceive on their own afterwards. So that is another thing that has to be taken into consideration while counseling, that we are
Yes.
freezing the samples for you,
Very
but
true.
after your therapy, after you wait for 3 years, 4 years, 5 years, whatever is required, whatever is a guideline by the oncologist, then after that, they may conceive on their own. So if they don't get the period, if it is a married couple and their wife doesn't get the period, she should not just wait thinking that, oh, I could not have conceived on my own. So that counseling has to be done at that stage. Now, a few other things I just want to mention. Let me read what I have made notes of. That, every center should have vibrators. Then there are some patients who are not able to produce semen samples. I've had one patient like that, and electroejaculation is required. I had 3 patients, but they were infertility patients. They were not cancer patients. But with electroejaculation, all 3 of them have produced children because they had good semen samples. Then another thing is that vitrification techniques have improved very well, the semen preservation techniques, and post-thaw samples are very good. So that is one thing to be kept in mind. And attention has to be paid to the to hypothalamo-pituitary gonadal axis, because some of these patients who are receiving some craniospinal irradiation the axis may be affected, and so we need to do their entire evaluation of the pituitary hormones, the testes and inhibin B, to find out if any of them need therapy, which may be hormonal therapy to help them with their fertility potential after the whole therapy of cancer is over. Now, the testes, we know, has 2 elements, elements in it. One is the spermatogenesis and the other is the endocrine. Endocrine is quite stable, and it's resistant to treatment, with radiotherapy and chemotherapy, so the hormonal damage is much less with cancer therapy, which is being given to the patient. But spermatogenesis, because it has rapidly dividing cells in it, just like cancer cells, they are also very prone to get damaged. So that has to be kept in consideration while giving chemotherapy, that the endocrine levels may be maintained, but the spermatogenic levels may not be maintained. So that kind of consideration has to be given. And childhood cancer studies which have been done have proved that when they have looked at survivors of childhood cancers who have gone into adulthood and who have got married and who then present with infertility, the incidence of infertility in these childhood cancer survivors is as high as 46% as compared to their own siblings who had infertility, and their incidence was only 16%. So childhood cancer survivors have a very high incidence of infertility, and that has to be kept in mind if they come back later on after marriage. And one has to go into the history of cancer treatment in childhood. Another thing which should be discussed with them if they don't want to, if they are considering tissue preservation or they don't want to consider, because they can always go for donor gametes, whether male gametes or female gametes, sperm or ova. oocyte donation is an alternative that they has to be explained to them that they can have that alternative available if they are not considering cryopreservation. And lastly, adoption is another alternative that should be offered to them later, right in the counseling stage itself, because some of them may not be wanting to spend so much money, on fertility preservation. And you can counsel them that they can save that money. And if they adopt a child later on, that money can be utilized to bring up that adopted child, which is a good thing for society also. So these are the things which I wanted to mention. And I want to congratulate both of you for the beautiful manual that you have brought out on Oncofertility. I was very happy to go through it. And there's a lot of information available. And the reference work that you have done to write that manual, congratulations and hats off to both of you.
Thank you. Thank you so much, sir. And thank you so much for describing very well and giving the complete insights all about the male strategies, male fertility preservation strategies, and as well as very important point to how we can team up and how we can have the dedicated oncofertility centers, especially in India, which is really, it's a work to be done from the scratch. And definitely we should start this initiative, because we should have the uniform guidelines, we should have the dedicated centers, only few, yes, where we have the multidisciplinary teams working together, all the facilities under one roof, as well as, of course, that is very true that all the options, even though we are preserving all the options like natural fertility, use of the donor gametes and adoption, it is very important to discuss at the beginning. And at the same time, we want to complete the circle, that is, after the treatment is done, after the complete cure, and after the follow-ups have been done, they have to again come back to the fertility specialist to discuss about all these options, how they can go ahead with the pregnancy. Thank you so much, sir. We'll move on to the next question.
Thank you for having me.
Thank you, sir.
Thank you, sir. It was a great, it was very nice listening to you, sir. You have given a complete holistic approach to a cancer patient. It was very nice listening to you, sir. Thank you.
Thank you.
Thank you.
Thank you, sir.
Moving on to our next clinical scenario. 15-year-old post-menarcheal girl who was cancer diagnosis is scleronodular Hodgkin's disease, stage 2 BB.
Okay, so I can request Dr. Bagal sir to give your insight in this case.
Yes. So again, a young person with a diagnosis of Hodgkin disease and stage 2B. And as I discussed earlier, first my goal would be to see what is her treatment required and what is her prognosis with that, and obviously the risk of infertility with that. Yes. So this girl just 15 years of old and she has a stage 2B disease, and she'll probably be treated with a chemotherapy only backbone, like 6 cycles of ABVD. And this probably looking at different drugs and the treatment outcome, this puts her at the low risk of infertility because of the treatment per se. But having said that, certain fraction of patient even in this early stage disease might fail and will require subsequent salvage treatment, and also very rarely stem cell transplant. So that is also have to be kept in mind. So definitely for such young patient, I would explain them the small but definitive chance of having infertility because of the treatment, and I will refer them for a counseling and if feasible some preservation of oocytes.
Okay, sir. So can I request Dr. Chaitra to give insight on this about the what fertility preservation options to this young girl?
Thank you, Snehal. Important for this young girl is, we have to discuss with her both from the treatment perspective and also from her psychological perspective.
Sorry, your voice is not clear.
Any child who's just 50, she'll be very confused when you go on. Okay. Yeah. Is it better?
Yeah, it's better. Yeah.
Okay, a 15-year-old child who has just started her periods, just understood that she's become a older adult, on the verge of being an adult. When you go and talk to her about fertility and do you want to become a mother and all those options may be confusing. So important would be to have a team approach, as has been emphasized together. Ideally a pediatric nurse or a counselor would be the person to go ahead. And one more important thing is there's something called as the ovarian reserve, the number of eggs that a girl or a woman would have, and what are the chances of having a good prognosis. In a 15-year-old, an AMH would not be the best option,
Yes.
because AMH would be better off from 22 years onwards. And also antral follicle count would be difficult, because
Yes.
ideally this girl would not be sexually active. So maybe a transabdominal scan, and if the oncology team agrees, we'll have to counsel her, or rather the parents, that probably there could not be any challenges with her fertility. And if there is time, ideally, yes, we could think of doing probably some cortical preservation,
Yeah.
or oocyte preservation, depending on what would be the best option.
Yes. Yeah, that is very important. Thank you so much. And definitely with this, we will just discuss on this part, what are the challenges in dealing with basically pediatric cancer population. This is very important, these challenges with respect to the ethical legal issues as well as the counseling. So I can request Dr. Anjali to speak on this.
Yeah, thank you, Dr. Snehal, for having me here. And
Yeah,
as
thank
we have
you.
already said, that fertility preservation is no longer just an idea; it is actually a medical specialty in its own. Definitely, young pediatric group of patients like those who are just pubertal or pre-pubertal, discussing these kind of things, they really need age appropriate counseling.
Yes.
And yes, we need to involve the pediatric counselor, we need to involve their parents. And because when these kids will they'll grow up, and if they would have they had to face infertility, then when these were asked that if you would have been offered these any fertility preservation techniques earlier, then they said that yes, they would have accepted that. So
Yes.
definitely, although it's just the beginning, but yes, these group of patients, they definitely needs counseling, and this counseling will be difficult because still we don't have any guidelines, and we don't have any appropriate persons for these counseling sessions. And yes, we need a appropriate environment. We need to give them psychological support, emotional support, and obviously, since these are pre-pubertal children, pre-pubertal group of patients. All the techniques which are there, like ovarian tissue cryopreservation, they are still, experimental, and they are in their experimental stages. So we have to, enroll them for these techniques, and we have to take permission from the review board
Yes.
if we are doing such techniques in these group of patients.
Yes, yes.
So that's all.
Yeah, that is very true. Thank you for nicely describing. Also, I'll mention about, yes, informed consent from the parents is very important, as well as we have to, with the age appropriate counseling, the child also has to be involved on this, depending upon the level of development and the maturity, and it is something called assent of the child. That is also important. And also here, there are certain, as you rightly described, certain situations where we need a clinical ethics review. So we'll skip this. So this is a workflow basically for the pediatric population. So mainly in this, the most important focus is involve the team, counseling, then counseling of the child as well as the parent, involvement of the both, and proper documentations and the consents, and definitely the different options. So these are the challenges basically. With that, moving on to the next question.
The next clinical scenario, 32 years, nullipera, mass in the left breast, 3 centimeters irregular, with a family history of maternal grandmother with a pancreatic CA, maternal aunt, a postmenopausal breast CA, and maternal uncle with melanoma. The cancer diagnosis is a core needle biopsy, invasive ductal breast cancer with ER positive 95%, PR positive 95%, HER2 and mu positive with no nodes.
With this, I would like to request Dr. Sampada ma'am to give insight on this case from your point of view.
Um, First, I would like to know she is married or not married.
She is married but nullipara, not having kids.
Okay. So she is diagnosed with breast cancer, which is ERPR and HER2 new positive.
Yes.
She has 3 centimeter lesion and has got no nodes. So this can be, since she is 32, one thing that we will need to consider is genetic testing, and she will be a candidate for if we have to consider the breast ratio, whether if she opts for breast conservative surgery and if the breast ratio is okay, she will be for breast conservative surgery with sentinel lymph node biopsy.
Yes.
But since she is nulliparous, we need to refer her for the fertility counseling, and we will have a time of at least a month.
A month's time.
Month's
Yes.
time for you to
To
do
work
a-
on. Yeah, so with, as madam has said, that with these cases, as you have rightly pointed out, that genetic testing is very, very important, because that we have the implication further like PGDs in that. And as you said, the month's time is available. So I would like to ask Dr. Suvarna, from the fertility point of view, what would be our options to these patients?
First of all, thank you, Dr. Snehal, for inviting me here.
Thank you.
Yeah, so she's 32-year lady. Yeah, genetic counseling is most important. And once she comes to the fertility specialist, proper counseling. And since we have time, I think we can go for a follicular start phase.
Yes.
Definitely, after the proper counseling, we can start with the stimulation. Antagonist protocol is a preferred protocol here with the agonist trigger.
Yes.
And as you have already mentioned in your previous slides, definitely we'll add on letrozole to keep the estrogen levels as low as possible.
Yes.
So as to, since she is estrogen and progesterone receptor positive, so that the levels of estrogen are maintained, and again, the flaring up of the disease can be prevented. And once agonist trigger and the pickup has to be done, and then we can do oocyte cryopreservation as, she's married, so we can definitely do embryo
Yes.
cryopreservation for her.
Yeah.
And once she's done with the disease treatment, she can follow up again for the embryo transfer.
Yes,
Uterine
yes.
embryo transfer.
Yeah, thank you so much, Dr. Sona. So, ma'am, as you said that it can be a breast conservative surgery. So, what are the things? Suppose now she goes further and we go for the pregnancy. Of course, as we have mentioned here, like some directed therapies, we need to give some time, like around 7 months after the therapy, or say if it can be 3 months. And as Dr. Suvarna rightly mentioned, we have a different protocols. But after the breast conservative surgeries, what are the possibilities like in the breastfeeding later on? In the
Contralateral
pregnancy.
breast, in the contralateral breast, she will have no problem.
Yes, okay.
It depends on the location of the tumor. If the tumor is centrally located and we end up excising all the ducts,
Yes.
then it becomes possible to breastfeed. But if it is laterally located tumor, most of the time they will be able to breastfeed.
Okay, okay. So those are the things. Okay. Thank you, ma'am. So we will move on to our next scenario.
Intervene?
Yes, yes, please, ma'am. Yeah.
Is PGD if since you mentioned she has got BRCA2 mutation?
Yes.
So in such cases, when you do embryo cryopreservation, do you do
Yes,
and
PGD,
see,
pre-implantation genetic diagnosis.
this is-
Yes, because ideally it is important to reduce the risk of transmission
So
to
you
the
routinely look at
offsprings.
the BRCA testing
Yeah.
in those embryos
If-
and you discard them?
Yes, yes. So generally the embryo biopsy is done. I think Sangeeta will be telling it is done at day 5 stage. So I think you can.
So what is the risk of losing that embryo if you do a biopsy of that embryo?
The chances are almost say 20%. Usually we do the embryo freezing on day 5, and we do the biopsy, then followed by that we freeze them, and the report usually comes say in a week or so. So anyway the transfer would be at the later stage. So those embryos which are like positive, then we discard them immediately.
Okay, but if you have done a biopsy of an embryo and turns out negative, the chances, there are 50% chances that a embryo will be positive.
That's
So, do you retrieve more embryos? In that case, you give more stimulation and retrieve more if it is BRCA mutated patient or something like that?
Especially, yes, with the stimulation point of view, as you rightly said, we are going to miss many embryos, and they will be segregated. They will be segregated. I mean, they will be frozen separately, and because to identify after we get the report and we discard them. Yes, as you said, ma'am, ki it is we have got 4 weeks time. If suppose, yes, we would like to go for the double stimulation. Ideally, yeah, we cannot have the hyperstimulation. It is always the control ovarian stimulation. But in such a situations, especially when we suspect these kind of genetic problems and if it is diagnosed, we would like to have the double stimulations, so that immediately after the one egg pickup, we immediately start the stimulation, which will be the luteal phase start. One is a follicular phase, one is a luteal phase, and we go for the 2 stimulations to have the maximum pool of the embryos. Yes.
Okay, even with the control ovarian stimulation, what is the range of estrogens as compared to your natural cycle?
Yes.
Especially if it is only ERPR strongly positive, HER2 negative, then it is ERPR driven tumor.
Yes.
So, or endometrial cancers which is ERPR positive. What is the range that goes as a high level of estrogen?
So, ma'am, in the natural cycles, basically, estrogen levels are maximally 250 picogram per ml to 300 picogram, which is necessary to have the positive feedback on the pituitary to give the LH surge. Maximum to maximum, they are like up to 500, less than that usually in the natural cycles. So as especially in such a estrogen sensitive tumors, either this one or endometrial carcinomas, we would like to go with these stimulations with the letrozole, because in the controlled ovarian stimulation with say around 12 to 14 follicles where eggs we are retrieving, per egg generally 200 per mature egg we have 200 picogram per ml is the estrogen level. So sometimes we expect it to be 2000 to 2500 picograms, but definitely with the use of the letrozole from the beginning of the cycle till we continue even after the stimulation, it will be maintained as low as 100 to 150 picogram, which is almost similar like or even less than that as that of like the natural cycle. And we have got like we have 2 types of aromatase inhibitor, letrozole and anastrozole, but instead of anastrozole, letrozole works better. It has been proven. Even instead of tamoxifen, letrozole is much better, because it with the dose of the 5 milligram per day, it can achieve this level. As well as after we retrieve, still the levels are higher. That time, we, along with the letrozole, we continue the GnRH antagonist to continue further, and we monitor the E2 levels every 48 hours. So as till the time they are below 50 picogram, we continue this therapy.
Okay, and you found it to be normal. When you transfer it, is there a chance of losing that embryo? Is there a chance it is more higher than the normal IVF cycle? And is there a chance of having anomalies in that baby if you have biopsied that embryo? Is that risk there?
Biopsy per se, the biopsy is not in the inner cell mass. We do the biopsy in the trophectoderm cell. So,
Okay.
which actually doesn't mimic the inner cell mass. That's a drawback of it, but still we do the trophectoderm cell. So, so losing of an embryo is very minimal, though I wouldn't say no, but very minimal. The chances of aneuploidy, again, as I said, it's in the trophectoderm cell, not in the inner cell mass. So, which actually truly doesn't give the result of the inner cell mass. So, aneuploidy might occur, yes.
But the chances are minimal, because it is the routine technique and we follow that even in the routine patients also having the known genetic problem. But definitely because of these some side effects, it is not done as a screening. We don't prefer it as a PGS, which is pre-implantation genetic screening. We prefer it as a diagnosis when the known genetic problem is there.
Okay.
Yeah. Thank you so much, ma'am. So we'll move on to the next case scenario.
31 years, single, complains of postcoital and intermittent bleeding, history of a chlamydial infection, cancer diagnosis is CA cervix.
So here again, from the oncologist perspective, I would request Sampada madam to discuss about the CA cervix and the possible options, especially even in this case also.
Okay, she's 31 years single and having post-coital and intermittent bleeding. First thing, diagnosis of CA cervix.
CA cervix. Still, we have kept it open. Not, I have not mentioned stage and all because both the stages. Then we will discuss like early and the late stage.
So I hope it is proven by biopsy.
Yes, yes.
So first thing that I would like to look at is I would like to do a clinical examination, definitely to look at the size of the lesion and an MRI of the pelvis to look at the size of the lesion, depth of stromal invasion, lymph nodal involvement, and if it is proven by lip biopsy or by conization, I would like to look at the margins, as well as I would request the pathologist to look at the LVSI, whether it is focal, whether it is present, whether it is focal, or whether it is an extensive LVSI. So if the lesion is less than 2 centimeter in size, no deep stromal invasion,
yes.
preferably no LVSI, though it is not an contraindication and not always it is possible, and lymph nodes are not negative, not enlarged on the MRI, then this patient can be a candidate for fertility sparing surgery.
Yes, yeah.
But I would definitely refer this patient first to the fertility specialist, because sometimes we might end up getting it not a candidate for fertility sparing surgery.
Yeah.
So the options of oocyte cryopreservation or embryo cryopreservation needs to be discussed with her irrespectively.
Yes, ma'am. So for even if suppose for example it's an early stage and we are doing either conization or trachelectomy, so generally how much time you would give to us, like in the early stage, or if it is a late and we have to directly go for say radiotherapy first, so how would be the time frame?
Early stage you can have a 4 weeks time.
Okay.
It doesn't progress so fast as this thing, so you can have a 4 weeks time in which you can stimulate and keep the.
Okay, so in the early stage if we are looking and she's going for the fertility sparing surgery, so we have 4 weeks time. So I would just like to ask Dr. Chaitra about this case, like what are the challenges because of the CA cervix? Of course the option would be she is 31 year and the single, so maybe we'll go for the oocyte cryopreservation, but what would be the challenges from our side? Can you would you like to mention about that?
Depending on what the oncologists also, inform us. The first thing when a patient comes to us for a fertility preservation, we would call up the team from the other side to understand exactly, because they are the patients who have been with the oncologist for a longer time. So we would want to know what is the prognosis for this patient.
Yes.
And how much time do we have? If we have quite a lot of time, maybe at least 15 days to a month, then we could think of doing an oocyte cryopreservation.
Yes.
And if it is a later stage of CA cervix, then probably doing a transvaginal oocyte retrieval may be a challenge.
Yes, correct.
But,
yeah.
But if it is later stage, again, we'll have to go for an abdominal oocyte retrieval.
Yes.
With the understanding to the patient that the number of eggs got on the scan and what we actually have in the lab may be lesser, because transabdominal is a more challenging approach for the egg collection.
Yes, yes.
So that is something that we'll have to tell her.
Yes.
So again, it depends on the team approach and how much time the onco team gives to us.
Yes.
Depending on that, I would want to counsel this patient.
Yes, as madam said, we had 4 weeks time, so stimulation would be better, but then as you said rightly, there will be challenge in doing a transvaginal pickup. So here again comes the counseling part about it, like these are the challenges, number of the eggs we might get, they might be little limited. And of course further I would like to ask Dr. Anjali, like suppose this patient after treatment, she has had a trachelectomy, so we would face certain challenges in her pregnancy. So can you put some insights on that?
Yeah, so basically, if this patient, survives and she conceives and she has undergone a trachelectomy, then definitely she will be at risk of, second trimester abortion because the cervix will be short and it might just give away. So we have to counsel them appropriately that it is going to be a high risk pregnancy. She has to take, extra progesterone support, and we can also do a cervical encirclage in such patients. But again, it will be technically difficult because we will be having very short cervical length for the procedure to happen. So we might have to do it transabdominally. We might have
Yes.
to do a Schrodinger's and such things. And
Yes.
one more thing I would like to say that if this patient is for chemo radiation, then instead of doing a oocyte cryopreservation, we can go for an ovarian tissue transposition, or the shielding of the gonads,
Yes.
uh, wherein we can just remove the ovaries from the field of radiotherapy, and we can just fix it to the either to the anterior abdominal wall or to the paracolic gutters with the
Yes.
help of a simple non-absorbable suture, which can be cut once the patient completes her cycles of chemotherapy and radiotherapy, so that she can even have a natural pregnancy. She might not have
Yes.
to go for a IVF procedure.
Yes, that is
So
very
these are the
true.
other
So,
treatment options in this particular case.
Can I make
correct.
a comment here?
Yes, yes, ma'am, please.
Two things. Once we do a ovarian transposition, there are 30% chances that the ovaries might fail
Yeah.
because of the blood supply.
Yes.
We hang it up. Sometimes it can get twisted.
Yes.
Second thing, there is a scattered radiation that occurs.
Correct.
So a patient has to understand. Third thing, your retrievals becomes difficult with the this thing. When once they are in the paracolic gutter. Thirdly, when you irradiate that the uterus, I don't think so with so much high dose will
Correct.
be able to bear on the pregnancy.
Yes.
So
That is
pregnancy
very
with her
important,
is
yeah.
not possible. It will be a surrogate pregnancy.
Correct, correct. So especially if the radiation is our first option, in such a situations we need to tell her about the more important would be the uterine damage, because it will be a thin endometrium, fibrosis, it may not respond later, and even if it might be a miscarriage, either a first trimester, second trimester. So definitely the need for the gestational carrier, that is surrogacy, is very important in such a situations. Definitely with the early stages we can go for while taking all the precautions. That is true. Yes. So, yeah, we will move on to the next case.
Okay. Can I ask a question?
Yes, yes, ma'am.
Like the question that was asked for testicular tissue cryopreservation.
Yes.
Do we have centers in India where ovarian tissue cryopreservation is done, and do we have a center in Mumbai where we do ovarian tissue cryopreservation?
Yeah, so it is the same, ma'am. Basically, we still not have, we are not having the uniform guidelines. So as of now, we have got all the facilities where we can do all this, because in the routine patients of the, not a cancer patients, routine fertility patients, we do the testicular tissue preservations, and along with when it is the azoospermia, and we have got the good sperm retrieval, we freeze the sperm as well as the tissue. So those things are still in the experimental phase, though the ASRM has removed that experimental label from the ovarian tissue cryopreservation, but still in India we have to have the uniform guidelines for that, and that is very important that we should have those centers at as a one unit. It has to be a one team, because again the transportation would be a problem immediately once the surgery is done. As soon as the surgery is ongoing, it has to be in the same building where it is immediately transported to the lab and other processing has been done. So the techniques, the medias and everything, it is available, but we have to work on these things. So still
So at
we are-
present we don't have any
No.
facility of ovarian tissue cryopreservation in India. Right?
Yeah, so we have to, we can't practically do it. So all the facilities are there, labs are there, everything, but the practicality is not there. So we have to work on those things. Basically, we can team up and have these all things can be sorted out, but yes, it requires a regularization. Yeah.
So, the next clinical scenario is 29-year-old married female. The cancer diagnosis is primary mediastinal beta cell lymphoma.
So I would like to ask Dr. Pagal sir about this. So she is a case of primary B cell lymphoma, mediastinal, and she's 29-year-old married female.
Yeah. So again, as is true with hematological malignancies, the cure rates are very high with this kind of treatment. The treatment mainly would involve 6 cycles of chemotherapy with an infusional regimen called as REPOC. Now, this case aptly highlights the dilemma. So, some people with mediastinal mass would be in distress. They might have breathlessness, they might have cardiac tamponade, etc.
Yeah.
A kind of SVC syndrome or an emergency situation where we may not have time. But other spectrum, people would only have cough or sometimes B symptoms, etc. So depending on patient to patient, we will have a time, or sometimes we may not have time. Second thing is her long-term prognosis would be very good, like cure rates more than 80% and above. And again, the risk of infertility with the treatment which we are planning with 6 cycles is in the low risk, less than 20 to 30%.
Okay.
And definitely she is in the reproductive age, and even for that kind of risk, I will not take a chance, and I will send her for counseling and appropriate preservation procedure.
Yes, sir. So if suppose that those are not other complications, and we get, usually do we get 2 to 3 weeks time for these kind of patients?
Yes, should be possible in most of the patients.
Okay, okay. So I would like to ask Dr. Suvarna how we can go about these patients.
Yeah, so again, she's a 29-year-old married lady. So definitely after counseling, the option of embryo cryopreservation is open to her. And
Yes.
if there is any urgency, we will immediately start according to the random protocol. But
Yeah.
yes, if we have time, then it can be planned. Again, it will be an antagonist protocol with an agonist trigger, because we want to prevent the ovarian hyperstimulation and the complications related to ovarian hyperstimulation to this patient. And yes, and if random start, if it is a random start, we have an emergency, we can start in any phase of the cycle, may it be a follicular or late follicular, or in the even the luteal phase, as very well explained by you earlier.
Yeah.
Yeah.
Yeah, correct. So basically we have got, depending upon the time, we can decide the stimulation protocol and we can go ahead. And definitely, as sir had said, because it's a mediastinal mass, there can be other complications. So we should have the high risk team with us, the intensivist medical team and anesthesiologist to be involved in those things, and those risks have to be discussed. And as well as in the hematological malignancies, the risks of the platelet dysfunctions and the bleeding and all at the time of the pickup, that is also there, as well as the risk of the thromboembolism. So we might sometimes start a low molecular weight heparin during the stimulation, and it can be stopped just 24 hours prior to the pickup, and then immediately we can restart 12 hours after the procedure. But of course, that will be, those decisions are based on the team approach. So yeah, we will move on to the next case.
The next case scenario is a 38-year-old Nalli Gravida. The cancer diagnosis is stage 1A1 endometrial carcinoma, diagnosed on dilatation and curettage sampling.
Yeah, so I would like to ask Dr. Sampada ma'am's opinion on this about the endometrial carcinomas.
So she's 38-year-old. I would like to ask the pathologist first for the grade of the disease.
Yeah.
Would like to do a MRI to look for the depth of myometrial invasion.
Yes.
Definitely, since she is Nalli Gravida, I will refer her to the fertility specialist. Since she is 38, obviously we'll look at the AMH levels,
Yes,
and
yes.
then decide on the treatment.
Yeah.
But this patient will be, if it is stage 1A, grade 1 endometrial carcinoma,
Yeah.
preferably not infiltrating myometrium, limited to the endometrium, will be for the fertility preservation protocol.
Yes.
But some of the times when we give this fertility preservation protocol, there are chances that they don't respond to high dose progesterones. So what is preferred is that you cryopreserve the embryos, you cryopreserve the ova prior to this thing. So even if she ends up in a hysterectomy,
Yeah.
you have a cryopreserved embryos and then go ahead with surrogacy.
Yes, yes. So even sometimes this progestational therapy or the like fertility preservation strategy doesn't work, then we have those things. And definitely here that this is important, that it is like sometimes some patients, they conceive naturally also if they respond well, if we are monitoring like every 3 months, and if they conceive, and then even after the delivery, you would recommend to go for still a monitoring or directly a hysterectomy. How would be your approach like?
When we counsel them for fertility preservation, we upfront tell them this is only for the childbearing,
Okay.
and
Yeah.
we encourage only a single childbearing because we are also at a
Time.
yeah,
time is
it is
limited,
not a,
yeah.
we have to explain to the patient that this is not the standard of care
Yes.
treatment for endometrial carcinoma, and they have to complete the hysterectomy after the childbearing is over. But there are patients who have requested for second pregnancy, and you sometimes you become emotional, and
Yeah.
that is given to the patient.
Yes.
But preferably maybe one childbirth, and then you go for the completion.
Yes.
Sometimes when they have not responded, we do give them an option. Endometrioid carcinoma is a hormone dependent tumor. We can preserve the ovaries, but
Yes.
even if the ovaries are preserved, we have to go in again and remove those ovaries at the end of the treatment.
Yes, yes. Okay. Thank you so much, ma'am. So with this, we'll move on to the next case.
23-year-old Nalli Gravida with a history of right salpingo oophorectomy for stage 1A borderline ovarian tumor. Current diagnosis is left adnexal mass.
Okay. So again, I would ask Dr. Sampada on this. Now she was had a one oophorectomy, which was for the borderline tumor, and now again the adnexal mass. So what are the chances that again she would have to have the oophorectomy, and how much time we will get in between?
We have to check the size of the adnexal mass, see if there is some normal ovarian tissue is remaining.
Okay.
When she has already got one side borderline ovarian tumor, if she has got a normal ovaries, we will like to see whether the initial tumor was ERPR positive.
Yes, that history
If
is
it was,
important.
most of the time they are ERPR positive. So if it is a ERPR positive, and where there is a very little, if the large amount of ovarian tissue is left, we would still do only the mass removal and leave behind the
Normal tissue.
normal
Yes.
tissue. But if it is entirely gone, then I would not prefer it to be stimulated by
Yes.
this thing. Rather go for a donor egg. And
Correct. So those options also have to be discussed. So I would like to ask Dr. Chaitra on this, her insights.
Yeah, this is a difficult case scenario because we have already removed one of the ovaries, and there's the other ovary which could possibly also have a borderline ovarian tumor. So again, extensive counsel is required, because if at all it's truly a borderline ovarian tumor, the patient has a right to ask, if you had removed that particular ovary, then am I living with a cancer, or am I at a risk of any other problems? So I think important to counsel that probably not a bad idea to remove this ovary also, and give the option for HRT as well as donor egg.
Yes,
I think I would agree with Dr. Sampada on this.
Yes, yes. So these options in such a situation, sometimes like a critical or dilemma, so we have to have the options of the donor eggs with us. Then we'll move on to the next case.
Here it's a 22-year-old woman, Nalli Gravida, with a current diagnosis of recurrent Hodgkin's lymphoma requiring bone marrow transplantation as early as possible.
So I would like to ask Dr. Bagal on this. In scenarios where we especially have taken this scenario for the basically requirement of the bone marrow transplant. So one is the how much time we have and the prerequisites, especially the radiations and all. So can you mention those points?
Yes. So regarding the risk of infertility, it is very high. It is almost, though there are some regimens where it is low, but you could consider the highest risk of infertility. Now her further treatment would be in 2 steps. First is to get her disease under control, so that would be an induction chemotherapy or a salvage regimen.
Yes.
And depending upon her general condition, probably we will have some time for oocyte preservation, in my opinion. And whatever we want to do, we have to do it before the salvage regimen, because salvage regimen has to be followed by a transplant immediately. So definitely she requires the fertility preservation.
Yes, definitely. So I would like to ask Dr. Suvarna on this, our approach from the fertility side.
Yeah, so first of all, counseling most important. Yeah, we have to counsel the patient correctly. If as we have very short time, again starting the stimulation as early as possible, and she has to be appropriately counseled about the quality of oocytes that we may have, and there may be a requirement of donoric, but at least she will be at content that at least a trial has been given, and we can go ahead with the stimulation and get characterization for this
Yes,
lady.
definitely. And here also one point to mention that we need to understand about the ovarian mets and ovarian involvement,
Ovarian,
because
yeah,
yeah,
involved.
we cannot then have the retransplantation of those tissues, and other, of course, we have
Yeah,
discussed
ovarian.
other problems for the hematological malignancy. And at least if suppose any other possibility, any other option we cannot give, at least in such a situation we give the GnRH
Yeah, at
agonist
least
for these patients. If they are not opting for any other options, at least it is advisable to go for the GnRH agonist, which is like a
ovarian. Yeah.
chemical shielding. Then this is
Shielding.
one more interesting case. We are almost at the end of the discussions, but this is one unique case we'll discuss.
A 34-year-old primary gravida, the current diagnosis is acute lymphocytic leukemia during her 17th week of pregnancy.
Yeah, so this is the very unique case where she is already pregnant 17 weeks and she has been diagnosed as ALL. And so first I would like to ask Dr. Bagal on this, how would be the approach, and then we'll come to the fertility team.
Yeah, so I think it's a difficult situation. This being acute lymphoblastic leukemia, this is a rapidly progressive disease. Most of the time at presentation, patient would be anemic, they would have thrombocytopenia, etc. So treatment of ALL has to be started, as it is a kind of a life-threatening situation. And very rarely, if someone is, for example, a third trimester, or where you think you'd be able to do a early delivery. In such situation, you might have time from case to case basis, but irrespective of the gestation age, the treatment would be required. So this is the difference between lymphomas and leukemias, where this is a real emergency. Even few days delay could be detrimental. And obviously, we'll have to explain to family the effect on the child or baby, and also the effect on the future fertility for the family.
Yes, definitely. As you rightly said, that even if she is currently pregnant, but we can't underestimate her desire to have the another kid, and that can be discussed. And we can have the tissue preservations also in this. Laparoscopically, the ovarian tissue strips, cortical strips can be removed. And yes, as you said, as early as possible, because she is in the second trimester, we can give the chemotherapies and early delivery. So we need all the high risk unit available. So yeah, so we'll move on to the next question.
What are the challenges in survivorship when the fertility preservation options were not offered during cancer treatment?
So I would like to ask Dr. Anjali to comment on this.
Yeah. So basically, if a cancer patient has survived, because with improved diagnostic and treatment modalities, the 5-year survival rate has really improved, especially in stage 1 and stage 2 cancers. So the next challenge is to have a good quality of life, and it is the dream of every couple to have their own biological child. So definitely, fertility preservation, oncofertility, comes into play, and many couples who had a cancer and then they recovered, and then when they were asked that if these kind of techniques were available, that would have gone for it, then they said yes, definitely. So we have to oncofertility definitely has a role, and all the patients who are who are having cancer, they should be referred to a fertility specialist to understand what are the available options for them according to their stage of disease and their survival rates. So yes, definitely, this oncofertility does play a role in improving their quality of life. once they are, they are cured of their cancer.
Correct, very rightly said, because it is very important to, all the patients to get these things, because very recently we have got, I would like to mention this recent case with us. She is herself is a pathologist, and she was diagnosed as a early stage breast cancer when she was in her 30s, I think 31 age. But that time the fertility preservation was not discussed with her, and then she underwent breast conservative surgery and the chemo. But afterwards, when the disease was completely cured, after say 5 years, when she is now at 36, and she of course her AMH was very low, and then she had underwent the first IVF cycle with the self eggs. It was I think it was only 2 or 3 embryos formed, but there was a miscarriage. Then that was lot of regrets of not having the counseling, not having preserved her own eggs, and it was lot of sessions we took for her, to understand, okay, and then further options of the donor eggs. Then definitely after those counseling sessions, she went for the further IVF with the donor egg. It was all good. Now currently she is 5 months pregnant, but definitely that regret is there in her mind. So that is very important importance. So that tells us the importance of this topic and importance of this discussion at right time. And now this is the last discussion of our today's panel. Yes, so we'll discuss on
What are the ethical and the legal aspects of oncofertility?
So basically, I would like, so this is like a open to everyone, so you can comment like it should be offered to whom, and what about the financial considerations, and what about the disputes, and these things, and about the posthumous assisted reproduction. So I think the first 2 questions I would like to ask to our oncologist, their opinion about to whom they would like to offer, and what about the financial things, and other part we can discuss. So first I would like to ask Dr. Bagal on these 2 points. Like, would you like to, ideally, yes, as per the guidelines said, it should be to everyone?
Yes, so I think as you said, no, better to have the discussion upfront rather than later on regretting the thing. And it should be considered in each and every patient, especially given the improving outcome nowadays. And I think facilities are also becoming available to us.
Yes.
Even we have some strategies to, for example, to buy some time or tide over the crisis. Meanwhile, we can do this. So it should be definitely at least discussed, and appropriate assistance can be taken from our respective colleagues.
Yes,
As far as
sure.
financial consideration is concerned, this is sometimes a challenge, definitely. And the cost of treatment also has to be kept into mind, and some of these techniques are really something to think for our routine or maybe general category patient. But definitely having guidelines on this, getting them approved through the insurance and reimbursement through their service provider is important. And that is why the point which was discussed about having guidelines for our patient is important, so that they can get it reimbursed. So definitely there are challenges, but we need to be active and think about this in the first go, so that we give them the chance not only to be cured but have a normal life afterwards.
Yes, sure. So I would like to ask Sampada ma'am also on this, like how we can, improve this, and collectively together we can improve these 2 aspects. So about the counseling to be offered to everyone, and mainly the financial concerns.
Yes, counseling is to be offered to everyone.
Yes.
We need to take into consideration the prognosis of our
Yes.
stage 4 CA cervix. I will not.
Sure. So all the
Definitely.
curative treatments
Yes,
definitely will go
yes.
for,
Early
not
stage,
the
yes.
palliative ones.
But the counseling is to be offered to everyone,
Yes.
so that everybody is aware of this thing. Another important comment I want to make. It's good that you are doing this oncofertility workshops.
Yes.
It is not that every oncologist or everybody who is treating cases are aware about all these techniques that
Correct.
are available.
Correct, yes.
Even in the rectal cancers, there are patients who receive neoadjuvant chemoradiotherapy without ovarian
Yes.
transpositions.
Correct.
So these things making the oncologist
Aware about it.
because the gynae oncologist might be
Yes,
aware about
of
the
course.
ovarian transposition, but the radiation oncologists sometimes are not, may not be, because those techniques were not available at that time. So
Correct.
it is important that we make this awareness
Yes.
among the oncology community also, that such techniques are available.
Yes, and
Fine.
each field, sorry to
Yes.
interrupt, yeah, like not just gynae onco or
Yeah.
pediatric onco or just hematological. So it should be each and every oncologist should be aware about it, and especially who is dealing with the any patient of the pediatric, young adult, and the reproductive age group. So I think that is very, very important. So we have to reduce this information gap
Yes.
between us. Yes.
Financial consideration, yes, it is fertility treatment. The moment something comes to infertility, the insurances don't support. But I think something should be made about
Yes.
it, because it is the quality of life that we are looking.
Yes.
Especially these early stage cancers are long-term survivals, and we should be looking at the quality of life issues.
Yes.
And the insurance consideration should be
Should
given.
be there, and probably, ma'am, as NGOs they are looking, because I think I saw in the conference also we have a workshops on NGO, so I think there also they can discuss these topics, because this is also one of the factor of the cancer patients when we look at the person whole and the complete well-being. So definitely this factor matters a lot, and so that is one. And of course insurances companies should consider this as a iatrogenic complication of the cancer treatment. So definitely we should have some consideration. So I think the right guidelines and some kind of the consortium will definitely help on this. Yes, and then to our fertility specialist, I would like to ask, like, whenever can you comment on this, like disputes on the frozen gametes and embryos, and about even the posthumous assisted reproduction. So first I would like to ask Dr. Chaitra on that, how we can prevent that, especially you can tell a little bit about the consents and other things, the importance.
Yeah, very important in our field, infertility, to explicitly take consent from the couple, if the couple is married, as to what happens to the gametes, individual sperms and eggs,
Yes.
or the embryos which have been formed, if at all they separate or one of the couple dies. That is
Correct.
important, especially also if the one of them has got cancer which has a higher risk of having morbidity and mortality. So it's important to be explicit on the consent form as to what happens to the fate of the gamete legally. So that should be mentioned from both the husband and the wife, and individual consents are taken, not as a couple.
Yes.
So we take one from the husband and one from the wife, so that legally tomorrow, if at all there's a dispute, not necessary that the husband or the wife, the cancer person should die. If at all they are unable to take a call, they lack the competence to take a call, then the fate of the gamete should be decided from that piece of paper. So it's important that we document it and store it in a safe place. So
Correct.
that's important.
So that is very important for the documentations and the consent part. So I think here we end our panel discussion and making a note on this, that of course this is a ideal model of care for the fertility preservation which has been given by the ESHRE, and it's our important focus should be to find work hard to develop such kind of the oncofertility unit which is well coordinated, having all the facilities, and we can do best to our patient to improve their quality of the life. Of course we have discussed all these key points. Again, I will not go in details, and I think over to Sangeeta. She will just talk about our 2 minutes for our book, which is a sincere effort for all our oncologists. So we have tried to simplify all this, which is very easy for the clinician to go, not as a reference book with many studies and many references. So over to Sangeeta.
So this Oncofertility manual, bridging the gap between the oncologist and the fertility team, it's a very concise book where it's all deal with the practical aspects, and it's very easy, and even for the upcoming oncologist and the fertility specialist, it would be easy for them. And I guess even Dr. Tibrewala sir was very happy with that book, because it's very written in a very concise manner.
So yes, so thank you. I would like to thank the organizers and definitely giving us this opportunity in the conference, and this is very important to have this kind of workshops, and we are very happy to make aware these things like oncofertility care and oncofertility team, and definitely however times we would like to do this because it is very important that each and every oncologist, each and every oncosurgeon should be aware about this, all the options, and definitely we can starve hard to make the ideal oncofertility unit. So this is just here we have this official launch of our book. So thank you so much for your support, and with this we end the workshop here. Thank you.
Thank you.
Dr. Snehal, I must say that this
Yeah.
book is really nice and very well concised, and it's very
Very
easy to
good.
understand.
Thank
I
you so
actually
much.
read it in just 2 days, for preparing for this panel discussion. I just read it in 2 days, and it was so easy and it's so easy to understand. I would really like
It's
to
a well written,
congratulate
yes.
you. It's a
Thank
very
you
well
so much.
So
Thank you
it's
so
a
much.
well,
written
thank you
book.
for the copy.
Yes,
Thank you
yes,
very
thank
much
you.
for the
And
copy.
yes, I
It's
have to yet send it to
recent
Dr.
time.
Bagal because I didn't get his address, but definitely I'll be couriering it to you.
And very well written, very concise and precise to the point. It is.
And interesting.
Thank you so much.
Interesting
Yeah,
also.
yeah.
It's a quick read.
Thank
So
you
it's
so
a
much.
very
Thank
well
you.
written book.
And I really thank all the panelists, Dr. Bagal, Dr. Joshi, Dr. Sampada ma'am is here, and all Dr. Chaitra from Bangalore, Dr. Anjali from Allahabad, Dr. Suvarna from Pune. Thank you so much for gracing our workshop, and it was great insight from all of you. And thank you, Dr. Ashay, for giving the opportunity to us.
Yeah.
Thank you.
Yeah, actually, even I have read the book. It's wonderful. I have finished in one day. Actually, I mean, there are so many other aspects were there actually in this particular book. Actually, I was never even thought about, even including small medical legal, I was actually discussing Dr. Mangesh, even if you're stored and even the patient is no more, now what is next? Because these issues we never even think about it, and I think it's a really good initiative. I'm encouraging Dr. Snehal also that she should come to, all oncology institutes also, and she should deliver these, lectures or workshops. There are guest lectures, especially even Tata also we can organize. I mean, Dr. Bhausaheb sir is there. Even Dr. Vijay Patil is there, Dr. Kumar sir is there. So definitely we are really looking forward, because actually even as a student, I was discussing that, many times we don't even discuss these issues with the patient. We take it for granted that, this patient doesn't require, patient cannot afford or patient cannot go for it. So I think this is a very burning issue, which is actually we are pointing it out and discuss. Even last time it was virtual, this was hybrid. So hopefully, next time it will be completely real. So everyone can interact very well and can attend this meeting. Thank you for these excellent insights. Thank you all the panelists, for these wonderful discussions. Thank you everyone.
Thank you so much.
Okay,
Thank
sure.
you.
Thank you, Asha.
Thank you.